For the agent that must be in the know, Medicare Industry Insider discusses critical insight, noteworthy trends, and upcoming issues in the Medicare market.
Deciphering and debating the legislation, regulation, and what's happening in the market, I'm Jalen Jackson.
And I'm Rachel Bremeyer, and we're going to talk shop, dive deep into these complex topics, and make them understandable and actionable.
If you've ever wondered where the world of Medicare is going and how to prepare for the future, Medicare Industry Insider is the resource you've been looking for. Welcome to Medicare Industry Insider, everyone. I'm Jalen Jackson.
I'm Rachel Bremeyer, Executive Sales Director at Senior Marketing Specialist.
Yep, and I am the Compliance Officer for McNerney Management Group, and we're going to talk a little bit today about rural hospitals and some of the challenges facing them. As we've told you in the past, we both have about 20 years of combined experience in the industry and love kind of demystifying Medicare and some of the things that affect our clients. So today, I want to dive into rural hospitals, some of the statistics and information regarding their closures, their payments, why they're at risk of kind of devaluing the care they're able to provide, and what that means for your clients.
Yeah, essentially in the last 10 years, we have seen an ungodly amount of hospitals closing, specifically rural hospitals. And this is due to a lot of different things between payment models, changing models of care, and overall just what rural hospitals are able to do preventatively and comprehensively if a client or patient goes to those hospitals. So to throw out some statistics so we can kind of go back and forth, but we were pulling several things, and according to Kaiser, from 2010 to 2019, 114 rural hospitals eliminated inpatient services or closed altogether, which is just crazy. If we're looking at Missouri, which is our state, in 2014 to 2020, there was a total of 15 closures. So we're looking at quite a few closures, even just in our own state, some of them right in our own backyard.
Absolutely. I think there's a lot of reasons that hospitals are facing some of these challenges. And I know if you follow the healthcare industry at all, I don't think anyone in the healthcare ecosystem that is not at times at least kind of strapped for cash or at least facing some financial issues. Now, don't get me wrong, there's folks making out like bandits. There's some folks working the system really effectively. But I think with all these rural hospital closures, it follows some pretty significant trends, not only in the market, but in how we receive care. But back to kind of the market side of it, I think as we've continued to see continued investor interest in the healthcare space from venture capital and large investment firms, we've continued to see some issues even here in our own backyard with how that can play out on the client side.
Right. And I think another aspect of it is just staffing those rural hospitals. If you're looking at statistics for that, only 10% of physicians in the United States practice in rural areas, despite that being about 14% of the population where they live. So you're looking at just a disproportionate ratio of staffing for one area versus who all needs that care. So we're running into a lot of things between the closing and then also staffing, but we'll dive into a little bit more on how hospitals get paid, because I think that'll help a little bit more in terms of understanding why some of these hospitals are closing as well.
Sure. And I think the big thing to realize is there's a lot of income sources for hospitals other than just someone going to the hospital to get treatment. And there are a lot of things that a hospital might do that may actually be in the patient's best interest that can actually reduce the amount they get paid. And I'm talking specifically about things like actual inpatient admittance. Hospitals are ranked and rated and measured based on readmittance rates, among many, many other quality factors. But it's often a lot less likely for someone in a rural hospital to be admitted as an inpatient because of a couple of factors. One, it can actually really hurt those readmission rates that can affect their payments. And also, it's really likely that that patient is going to have to be kind of stabilized and sent on. Rural hospitals, as you mentioned, are cutting departments, cutting services left and right. So a lot of times they don't have the ability to do that secondary or tertiary care. Someone gets shunted off to another larger acute and post-acute facility.
So let's walk through like a patient. Let's say they get cancer, for example. They're going to their local or hospital initially.
Sure.
And you mentioned stability first. So they're going to get that person stabilized. A lot of that time, if the person is on private insurance, that local hospital is getting hit with their original deductible. So then they're forced to try and collect that money from that individual instead of the insurance company, which can then cause them to not actually get paid because they're not getting reimbursed or getting payback from an actual insurance company, but from an individual person. But in addition to that, you did mention a really good point on having them get stabilized and going to the hospital that has better care. They're not going to put them as an inpatient. One, that's going to prevent them from getting some of those costs as inpatient or getting reimbursed as an inpatient, but it's also going to, they're playing this game of like are they getting, if they leave after 30 days and they come back, that can hurt them, that can penalize them.
Sure.
If they're an inpatient. So if they don't even count them as inpatient, then they're not getting penalized. So it's definitely this game that they're trying to play.
Absolutely, and I think it gets even worse with worse in the sense of patient outcomes with rural hospitals, because oftentimes they can be extremely limited in the specialties that they offer and the capabilities they have technology-wise. So a lot of times if someone needs that inpatient acute care, a lot of times that rural hospital may not even be equipped to provide
100%.
it, which again reduces the number of inpatient admissions. And hey, I think one of the other big things to talk about is how many hospitals have a tendency to, on occasion, kind of convert some of those acute care beds to, say, like a Medicaid swing bed.
Yeah.
Actually providing that more of that long-term care or skilled nursing care in the hospital setting as a way to generate some additional revenue. And granted, we're talking about Medicaid paying the bill, so it's still not
which
a
is
lot
not
of
ideal,
revenue.
but it does give them an option to get reimbursed, especially if a lot of their reimbursement is coming from individual people and they're probably spending a lot of money on collections and things like that. At least they know that Medicaid will pay, even if it takes it a little bit longer to pay.
Absolutely. I think one of the other things, if we look at what Medicare is doing, and we'll talk about critical access hospitals here in a little bit, but if we're looking at what Medicare is doing in terms of trying out some innovative payment models and how to actually deliver care at lower costs and higher profits for the hospitals, we look at things like ACOs, accountable care organizations. And we've seen some success with those and some trials with those around the country, but it's extremely difficult in a lot of cases for a rural hospital to enter into an ACO type agreement just because they kind of don't have that healthcare ecosystem to rely on. It depends on a large number of providers, specialists, primary care, hospitals, a large number of providers working together to form that accountable care organization. It's really easy if you talk about a large health system that has all of those specialties in primary care in-house. They can create their own ACO. Even in a more suburban market, perhaps disconnected providers can still come together to form an ACO for the purposes of those payments. But if you're talking about a rural hospital where the nearest cardiologist may be 2 hours away, that's really difficult to consider that an ACO in terms of promptness of care and access to care. It makes it really hard to enter into that type of kind of novel payment model that could increase their bottom line based on those patient outcomes.
And we've definitely seen a lot of buzz in the industry about ACO models. So they're basically getting left out of this new option that potentially could be a game changer in our industry, and they're left out because of networks and ability to service and access care. So yeah, I mean, it's definitely something interesting to look at of how our hospitals getting paid. Also, we haven't touched on this yet in terms of how they get paid, but they also deal with certain quality measures that I think we kind of touched on it a little bit of admitting as an inpatient and then having them leave and then come back. That's going to actually penalize someone, penalize the hospital if they're in that situation as well. So it is interesting. In April of this year, actually, CMS published a proposed rule that would actually pause the circulation and reporting of hospitals. So basically what that's doing is causing them to not be penalized financially, and so they're not getting that normal safety regulations that they would have normally gone through. And this is kind of a post-COVID type thing they're doing to try to help a lot of these hospitals too.
Yeah, and it's really this double-edged sword. A lot of times these critical access and rural emergency hospitals are oftentimes kind of exempted from a lot of these quality measures and penalties that go along with them. They're still assessed on those quality measures, but they don't actually see the penalties, and it's really difficult to look at, say, this struggling rural hospital that serves a community that really needs access to that care, and say, hey, we're going to take money away from you.
For sure.
It's also equally really difficult to say you're not meeting our quality metrics, but we're not going to do anything about it. So I think it's that if this then that, how do you manage those quality expectations without damaging access to care? And I don't think CMS has a good handle on that. They can't penalize someone who's already just barely staying afloat without making things worse, but they really need to work on those two big things: patient acquired and hospital acquired infections and other conditions, bed sores, things like that, and then those readmission rates. So you've got a lot of problems that maybe don't have a solution yet. And I think, unfortunately, as we're about to talk about, this critical access hospital designation may or may not help some of these rural hospitals.
Yeah, so let's talk about that. You led in perfectly to like the next bullet point that we wanted to go into, which was ER designations and critical access hospitals, which is an option for hospitals that may be drowning or not able to actually stay open as a traditional hospital. Pivoting over to a critical access hospital or an ER hospital is an option. Again, that's going to be a situation where a person, if they are going to the ER, they're going to get stabilized, like you said, and then get shipped off. So then we're going back to what we talked about originally of them having to submit deductibles instead of once that deductible is hit, which is usually in the larger hospital, and they're getting payback from larger insurance companies or whatever they're insured by.
Yeah.
So it's definitely a catch-22, but it's an option.
And I think you hit on a big problem. The critical access hospital designation really helps on the Medicare side by offering things like those cost-based reimbursements rather than based on actual, normal Medicaid reimbursement rates. But some of those requirements, 25 or fewer inpatient beds, located more than 35 miles from another hospital with some exceptions, and then maintaining an average length of stay of 96 hours or less for acute care patients. Those are things that really impact a hospital's ability to access that commercial payer market, which is where they can make some of that money. They still have to contend with deductibles and things like that, but elective surgeries or things that they could be getting done at some of these rural hospitals now may no longer be happening if that hospital wants to become a critical access hospital. So it can definitely help them on the Medicare payment side, but it doesn't do a lot to help them and can actually hinder them in attracting people with commercial insurance, those commercial payer clients that can help their bottom line.
Yeah, I mean, it's such a catch-22. Rural hospitals, like you mentioned, they're all drowning. They're trying to figure out how to make it work, especially with, I would say, with COVID and all the staffing issues, which we didn't really touch on. But, I mean, that's going to be another aspect of how do they stay open if they don't even have people to service and take care of people. And overall just, finding solutions. So they don't have as many options with the ACO. They have an opportunity to stay open as ER designation. But think about your clients now. If you're in a rural situation, your clients get sick, they're probably going, further and further away to get the care they actually need. And this is just to stabilize them. So that kind of leads into the next conversation we wanted to go into, which is ambulance and airlifting, because if your local hospital is not technically a hospital, it's an ER hospital or critical access hospital, you're looking at going someplace else to get the care you need.
Yeah, and I think it raises a lot of interesting points. Like you already mentioned, ambulances or air ambulance, that can be a huge out-of-pocket cost, even in the best of cases, for a lot of clients, whether they're on Medicare or even on commercial insurance. But I think the bigger problem here that we've already alluded to is that continuity of care. People are going further and further away for specialized care, they get back in their own community, and if they have complications or if they need follow-up, it's way less likely to happen because they're so far away from care. My own mother faced that. She is a breast cancer survivor, and when she was getting treatments for breast cancer, they live up in North Missouri. The closest she could get was coming down here to Columbia, Missouri, to the university, which is almost 2 hours away. They ended up having some complications and issues and were not able to give her the care that she needed. She ended up having to drive even further away to Kansas City, which from them is nearly 4 hours. She was driving 4 hours, 3 days a week for chemo and radiation, and did that for months. And luckily she's in remission,
Thankfully.
Thankfully. But it makes it very difficult that if there is some kind of complication or emergent situation, she sure as heck can't go to Kansas City to see her doctor. She gets to the nearest emergency room, maybe ends up in an ambulance or, helicopter, airlift, and it can be a pretty big deal. So I think that continuity of care is almost even more important than some of those unexpected bills from an air ambulance or something like that.
Yeah, I mean, the bills are just one aspect. Looking at a study by the Government Accountability Office in 2017, an average price was $36,400 for helicopter, and it went all the way up to $40,600, which is just astronomical if you're like not expecting to get hit with that expense. And then I think you hit on the perfect other scary situation of continuity of care, that you're going to a doctor that doesn't know you now.
Sure.
And having, like, if there's an emergency, like maybe you've got some sort of chronic issue like cancer or anything, you have a higher chance of needing additional care, and your only solution is going to a critical access hospital or ER hospital. That's not going to, potentially that could hinder that person more than help them. So it's definitely one of those things that, as an agent, thinking through how you can help this client, whether that be, having that conversation with them, talking through that, knowing your networks, things like that.
Yeah.
It is pretty scary, and you've dealt with it firsthand. And then,
absolutely.
having to help your parents drive all the way to the hospitals, and someone's got to sit with her. And, if the spouse is working or something, then that's another aspect of who's paying the bills. So all of those things are things that, as an agent and a client, thinking through, what does that look like?
Absolutely. And I think, in this day and age, with all of the kind of more modern diagnostic techniques, the ways that we deliver care through telehealth, the way that we use technology in healthcare, it really puts rural hospitals even further behind, because in a lot of cases they may even be in an area, and it's hard to believe, 2023, we're sitting here and 69.3% of rural areas have access to broadband internet, which is fantastic, but that's still a good, more than a third almost, that do not have access to broadband. And that's based on some great FCC data. They have really cool interactive maps.
You and I were got into a whole nerd session of looking at cross-referencing everything. And
so you can actually cross-reference access to primary care providers per 100,000 residents and cross-reference that against percent of people who have access to broadband. And it's a fascinatingly interesting, if not very disheartening map to look at. Just seeing the number of people that don't have access to both or don't have access to either, which is hard to believe in this day and age. But when you look at someone's only option potentially being telemedicine, if they don't have internet access, we're talking about an actual phone call, not even a video call, and it just adds more barriers to care, not just things like medication refills, but also accurate diagnosis of basic issues that can later become emergent and result in a trip to that critical access hospital.
Yeah, so I mean, with telemedicine, it's a lot. You do need that broadband internet. You need to be able to see that person and actually pull them up on a video chat or something like that in order to see them. That's going to hinder these smaller hospitals to even take advantage of the telehealth, which was a huge benefit to a lot of hospitals during COVID when people were not wanting to get out of the house. And now post-COVID, where people may still want to come see you, but it gives people options, especially if, let's say that they have some sort of critical issue. Think about trying to get that person up and ready to go to the hospital. You've got to have someone take off work. You have to have someone then help them get dressed and put their shoes on. and then they've got to gather their medications. We've got to load them in a car. You've probably got several miles, if not, hours of time to get them to that right location. It's a lot of work. So if you have the option for telehealth to get that service done, like, that's all the power to that individual as well as the hospital. Sometimes it's just so difficult. It's a whole day event to get someone in a critical condition situation to a hospital or to a doctor appointment. So you've got that aspect, but then you also have, is it something that the hospital can actually do? And is it something that reimbursement is going to cause them to actually not be able to get them taken care of either?
Absolutely. And we're seeing a lot of that now, prior to, say, the COVID pandemic, public health emergency, like back in 2018, a lot of reports would have told you that the vast majority, I think it's only 9 states that actually did reimburse based on the kind of 3 main modes of telehealth, whether that was live video, remote patient monitoring, store and forward, things like that. But now with the COVID pandemic, we've had a lot of things loosen up regarding telehealth, a lot more access, a lot more ability to be reimbursed and to bill more things as telehealth. But as we've seen the public health emergency wind down, we're also seeing a lot of state-by-state restrictions go back into place.
Right.
And of course, the unfortunate thing is a lot of it has to do with some of those chronic conditions where it can be difficult for people to get out and about and access care, particularly things like opioids or other pain medications, anxiety medications, other things that are, for a lot of patients, very critical to have access to, but access to an actual doctor's office may be a lot more critical. And if they live in a community that only has one of these critical access hospitals, they may not have a specialist that they can go see to get that refill. So again, we're talking about that hours-long trip. And it's just really an untenable situation for a lot of people.
It's very give and take. You've got the telehealth option, which could take that person away from their local hospital, but it also gives the local hospital an option to collect money on a different avenue of care. But do they have the broadband internet to actually do it? It's a huge catch-22 of how is technology helping and hurting these smaller hospitals, rural hospitals.
It really is. And I think, and I don't want this to be all doom and gloom, because there are, with this technology and with everything else we've talked about, there's definitely some options and some opportunities for hospitals to remain profitable, remain functional. And I don't want anyone to think this is the end of local hospitals by any means, but I do think as an agent, you definitely want to be cognizant of what that local hospital can offer. And when you're sitting down and talking to clients about their care options, looking at, okay, where's the closest full service hospital? If they end up in that air ambulance, where are they going? Because that brings up a lot of network considerations.
Correct. Yeah, as an agent going through things like, how does Medicare cover ambulance or airlifting, especially if you're in a rural area, having that transparent conversation with them, talking to them about caregivers and who is that person collecting that data, because they potentially could be the ones driving back and forth those 4 or 5 hours and needing to lean on you as an agent to make sure they understand how it's covered and what's covered. And then, of course, as an agent, making sure that you've discussed some of those gaps in care too, like the financial devastation that a family could have with your example with the cancer.
Absolutely.
If you haven't had that conversation and they do get hit with something like a critical issue like cancer, you've potentially then put them in a financial burden where they're driving back and forth or airlifted and dropping, thousands of dollars to get them there. So having lots of conversations about gaps and knowing your networks is so important as agents.
Absolutely. And just a lot of opportunity to educate your clients in rural areas. Definitely have those conversations. Talk to the providers, see what they are able to do, see what they, where they like to send people, and then make sure you know what care your clients can expect to receive in the community and work on any initiatives to maybe improve that.
Great.
So definitely a lot of things to keep an eye on, a lot of discussions to be had with your clients and with local hospitals and providers. But end of the day, rural hospitals are going to continue to see a lot of struggles and a lot of opportunities, but there's a lot of kind of different initiatives to maybe bring them into the future technologically, bring in some new payment models, and definitely not something to panic over, but something to be aware of and discuss with your clients every chance you get.
100%. I think you hit a nice summary of what we talked about, so I'm going to leave it with that. Thank you so much for watching Medicare Industry Insider, and we'll catch you on the next episode.
Yeah.